A lot of times what oncologists are looking out for are driver mutations. Imagine that the cancer cell is like a car, so you want to target and you want to shoot the driver. That will make the car stop.
Hello, Dr. Thomas. How are you today?
I'm good, Tony.
Hey, thanks for your time. We are going to talk about chemotherapy, immunotherapy, and targeted therapy. I only know about chemotherapy. So maybe you can enlighten me the difference between all the therapy that you have in oncology. All yours, Thomas.
Actually, we have a lot more different agents to use for anti-cancer nowadays, but you rightly pointed out that there are these three big groups. So traditionally, we use chemotherapy because we use the fact that chemotherapy will kill more bad cells than good cells. And we are giving it in cycles, so we allow good cells time to recover.
Yeah.
So that's chemotherapy.
Yeah.
Targeted therapy is the use of antibodies that are directed towards certain targets that can be found on certain cancer cells. So as its name implies, there must be a target for us to use the medication. So nowadays, we are able to identify targets by testing the genes of the tumor. And if present, there are medications that we can use that's approved for use for some cancers. Now, immunotherapy is a game changer in the treatment for cancer. Yeah. So what is immunotherapy? There are actually many different kinds of immunotherapy. For example, there are vaccines for cancer. We also inject white blood cells that have been educated, all right, to kill cancer in the body, known as CAR-T treatment. But when we oncologists use the word immunotherapy to patients, it loosely means the use of this group of medication called checkpoint inhibitors. So what are checkpoint inhibitors? So the way our body works is very remarkable. There are bad cells every day in our body, so we either repair them or we get rid of them. And so one of the ways that we destroy them is actually to send certain signals for the cells to die, or to use the immune system to kill the bad cells. Now, one of the ways that bad cells become cancer is that they are able to prevent our immune system from attacking them. So they do this by putting a brake onto our white blood cells. So that's why it's called a checkpoint. Yeah, a checkpoint is basically a place where you stop, yeah, and check whether or not you are okay to proceed. So that's why some cancers, they are able to, stop the immune system from attacking them. Either that, or they are able to hide from the immune system. For example, imagine if you're looking for someone and someone is...
Sorry to interrupt. Yeah. Before we zoom in deeper, I want to ask you, how does chemotherapy, this is for our listeners, how does chemotherapy kill tumor cells, cancer cells?
How does chemotherapy kill tumor cells?
Yeah.
So generally, chemotherapy is because there is a selective principle, yeah? So chemotherapy targets actively dividing cells.
Yeah.
So it tends to kill cells that are more active in the body. And tumor cells are active. They're always trying to grow.
Including the normal actively dividing cells, right?
That's right. That's right. So therefore, one of the common side effects of chemotherapy is hair loss, right? Because hair is growing. Yeah.
Correct.
So they target cells that are growing. And therefore, when we give chemotherapy, we hope that the medication will kill more active cells. And we allow time for the so-called good cells to slowly regenerate. And we use certain indicators such as the white blood cell level in our body to determine that the regeneration or the growth of good cells is enough, and then we start the next cycle. So that's how it works.
Okay. What about targeted therapy? Just now you explained a little bit, but
so targeted therapy are antibodies. Yeah. So our body produces antibodies to fight infections. Yeah. So Yeah, so the very same way we are actually able to produce antibodies artificially, yeah, whether or not it's antibodies that we harvest from mouse, for example, or from human cell lines. So we are able to purify them, we are able to concentrate them. And these antibodies have a specific target. Yeah. So when we give this targeted therapy, it could be in the form of oral, it can be in the form of IV, yeah, injection. Yeah.
This
So
antibody is to target the cancer cells, the target
yes,
antigen in the cancer cells.
that's right. So there could be
Okay.
certain antigens, you are right. So antigens are proteins that are expressed, yeah, that can be found on the tumor cells. It can also be in the form of receptors that are present on the tumor cells.
So
So
this
when
one,
we,
for example, the receptor must be unique to tumor cells, cannot be
yes,
found elsewhere
sometimes
in
it is
the
not
normal cells,
purely unique. Yeah, sometimes it's not purely
not
unique.
purely unique.
For
So,
example, one of the commonly used targeted drugs, we target this receptor called EGFR. Yeah. So the E actually stands for epidermal.
yeah.
Yeah. So the very same receptor that's found on the tumor that we're trying to kill can be found on skin cells as well. So that's why sometimes there are some side effects still. It is not purely without side effects. And therefore, one of the side effects when we give anti-EGFR targeted treatment is actually rash.
Is there any receptors that are unique to cancer cells that are not found in the normal tissue, normal cells?
I would say that we try to identify mutations. Nowadays, we are able to sequence or identify all the different mutations in the cancer cell. So sometimes the mutation can be unique, and therefore targeted treatment. Sometimes you may end up just purely focusing on the tumor and they respond very, very nicely.
What kind of cancers are amenable to targeted therapy?
So I would say that almost all cancers, we are able to have some targets, but it doesn't mean that if someone has that particular cancer, he will have a target for us.
Okay.
What do I mean by that? For example, in colon cancer, yeah, half of the patients will be able to use, if they are stage 4, we are able to use an antibody that targets EGFR, like what we were saying. And the other half, we can use both, for example, because there's no resistant mutation. So we're able to use anti-VEGF, which is an anti-blood vessel antibody. So it sounds a bit complicated, but generally in most cancer types, because we have made so much advances, we have been able to identify targets in some patients.
Okay.
But usually each patient is unique, so that's why they have this term called personalized medicine. Yeah.
Okay.
So when someone is diagnosed with a cancer, his treatment actually does have to be personalized.
So different cancer cells have different targets. Let's
That's
say,
right.
for example, EGFR, you
Yes.
mentioned in the colorectal cancer, does it occur in other cancer in the body or just colorectal?
Okay. So I would say that EGFR, for example, can be also a different target. Yeah, say in head and neck tumors. Yeah, it's also
Right.
used in head and neck cancers. Yeah, and in a different context altogether, when we are treating lung cancer, we are actually targeting a different type of EGFR. We're actually targeting a EGFR mutation. Yeah. So different cancers have different targets. It could be the same receptor, but we are then targeting different parts of the receptor. So that's why it's complicated. And usually the oncologist will see, start treatment, identify targeted treatment, potential in the patients, and then discuss all these options with the patient.
Initially, you work on tissue first, right? The surgeon,
That's right.
you take biopsy or the surgeon remove the tumor and then send it to the lab. How do you
That's right.
identify what is the process to identify the receptor or target that in your practice?
So generally, there are a few ways. So from the tissue itself, we are able to identify receptors or certain proteins available, for example, by painting, doing what we call immunohistochemistry stain. So it's like painting the specimen to see if the tumor absorbs the paint or not. Yeah. So we are able to identify, for example, hormonal targets.
Yep.
We are able to identify certain receptor targets. For example, commonly in breast cancer, Herceptin or can be used for patients who are HER2, yeah, HER2 positive.
Okay.
So
And
that's one way.
okay.
Then there are other ways, for example, by actually identifying mutations in the gene of the tumor. So that requires a specific testing. We can either look for certain mutations, or we can actually just sequence and find all the known cancer mutations in the tumor,
Okay.
not necessarily relevant to just the tumor type. And that one is what we call a next generation sequencing. So we try to be as comprehensive as possible. But sometimes it doesn't mean the more you find, the better it is.
Mm.
So Tony, a lot of times what oncologists are looking out for are driver mutations.
Yeah.
So this is like someone who is driving a car. So imagine that the cancer cell is like a car and the mutations are, present in the car. So you want to target and you want to shoot the driver. All right, that will
Right.
make the car stop. You don't want to shoot, say, a passenger. So
Good analogy.
they are literally called driver mutations and passenger mutations. So it doesn't mean the more you find, you'll definitely be able to use a medicine,
But how do you identify the driver, not the passenger? How do you know if that is the
So,
driver
so,
or
so
the
that's
passenger?
why this is after many, many years of research and studying. Often at times, we know that certain mutations tend to be found in certain tumors. And for driver mutations, the results can be very dramatic. Meaning to say, if you find that particular mutation, for example, in lung cancer, the EGFR mutation, you give them the medicine that will block that mutation, the tumor responds very, very, very well.
Can
So
it
then we
cure?
know that's a driver mutation. Yeah.
Can it cure
Um,
the eradicate totally? Is it possible or not possible?
okay, so usually it's a bit tricky when we are talking about solid cancers. Solid cancers are what we call heterogeneous. And the opposite is actually what we call liquid cancers, loosely. So we're talking about leukemias and lymphomas. So the main difference is like if you watch Star Wars, Tony, for example, liquid cancers are like one whole group of stormtroopers. They all look the same. Yeah.
Okay.
Whether or not inside they're different, but they all look the same. If you have a means of killing one and you know you are very successful in killing one, you can give the same treatment and kill all of them.
Kill all.
Yeah, so that's called eradication, right? Now, the problem when we are dealing with solid cancers, whether or not it is breast cancer, lung cancer, or colon cancers, you're not dealing with a whole group of stormtroopers. You're actually dealing with a classroom, for example. Yeah, some people are tall, short, some people are fair, some people are dark, some wear glasses, some don't. Now, when you have a targeted treatment, you are targeting perhaps maybe the driver mutation, you may be able to eradicate most, but there will always be some student in that class who is very clever, who may just be keeping quiet for a while, that may later rise up, and say, you're not going to catch me, you're not going to target me, and
Yeah.
that's called resistance. Yeah, so resistance
Your
does set
analogy
in
is
after a while.
very interesting. Hey, Thomas, I watched a YouTube video. Actually, it's a news in Australia.
Mm.
Patients reportedly beating cancer with just one tablet a day. This one, I think, is talking about lung cancer.
Yes.
And according to the news, patient is cured. Is it possible or not possible?
I would say
You know
that
what is the medication they are talking about?
yes, that's right. So generally this is typical of a driver mutation. So it's typical of targeted therapy as well also.
This is
So you get
targeted therapy,
such,
talking about
that's right,
targeted therapy.
that's right. So you get such good results if indeed the patient has a driver mutation and you're able to block that driver mutation. But we are usually very conservative in using the word cure, especially if the tumor has already spread to many places. Again, that's because when the tumor disappears from the scan, we only know that it cannot be seen on the scan, but whether or not there are microscopic cells still in circulation, whether or not resistance can occur, because there are ways that the tumor can become resistant to targeted treatment.
Okay.
Because you see, the way cancer becomes cancer, so cancer was once a normal cell. The way cancer becomes cancer is that they are always changing. The main thing that we know about cancer is that it is always changing. It is always getting new mutations. It's always learning. So again, even if you have what we call a complete response, you really do not know if there are circulating tumor cells that are just changing, evolving, and eventually mutating to become resistant to the tablet. One of the ways that it can become resistant is to acquire resistance mutation. That's one. And two, it can actually, have a mutation that may prevent the medication from binding with it. So you can have a target, but if the target cannot bind onto the cancer cell, it cannot work.
It's
So
something
sometimes
like
they're able to change their shape. Yeah.
something like
And
virus.
that's right. That's right.
Viruses
So
is
viruses are
mutating, and
always
then
mutating as well.
the vaccine may not be as good as before, and right, something like that.
Exactly. Yeah.
What
So
about
therefore, we usually are afraid to use the word cure, but if someone has gotten a complete response, I mean, we usually will be very happy, we'll congratulate the patient, but we usually will continue the medication as well also.
so radiologically, if a patient has been found to have tumor and treated, it is possible to just disappear like that. I'm not talking about microscopic, radiologically. MRI,
Yes,
PET scan.
it's definitely possible. It's definitely possible for certain tumor types.
For certain tumor types. Okay, now can you enlighten us about immunotherapy?
So immunotherapy, as I was mentioning, is a very loose term. There are many ways that we can kill cancer. So using the immune system is one of them. Now, immunotherapy is not just about the use of checkpoint inhibitors like what we were talking about, but in general, if we use that term, when oncologists use that term, we are actually talking about checkpoint inhibitors. So a checkpoint is a place where you actually have to stop, have yourself checked before you can decide whether or not you're going to be stopped and or you can actually go. Yeah.
Okay.
So one of the ways which cancer cells can prevent the immune system from destroying them is that they are able to activate the checkpoint, right, of these tumor of the immune system to prevent them from being attacked. So checkpoint inhibitors are antibodies. So they are usually given as an infusion, as a drip. And these antibodies will go and block, right, the checkpoints. So basically, the tumor tries to stop the immune system. Yeah, the checkpoint inhibitors will remove the checkpoint so that the immune system can continue to attack the tumor. So it is not something which directly kills the tumor.
Normally, how does it work in normal people?
Okay, so normally, if you have a cell that is bad, and we're not talking about cancer cells over here, cells that are bad,
mutate,
our body will be able to repair them, right, to make them good again, or we are able to activate certain signals so that the cells will die, the bad cells will die, or our immune system will go and get rid of them. This is normal. Now, one of the ways that the bad cells then so-called graduate to a cancer cell is because they are able to acquire abilities to
escape this
stop the immune system from attacking them. And when the immune system cannot attack them, then they can continue to grow unchecked. Yeah, they can mutate and they can grow more and more, and then they can also spread. Yeah. So the immune system, if the checkpoint is removed by the immunotherapy, the immune system can attack them. So the immunotherapy doesn't...
Actually, the checkpoint works in our favor or in the tumor cells' favor?
Okay.
The checkpoint.
So we actually, for tumors, it actually works in their favor.
The checkpoint.
Yeah. That's right. So we actually do have checkpoints as well also, because Tony, do you know about conditions such as lupus, conditions such as thyroid, autoimmune thyroid problems, rheumatoid arthritis? Now, these happen because there are some patients whose checkpoints don't work very well. Yeah. So therefore, their own body immune system attacks their own normal cells. Yeah.
Okay.
So therefore, checkpoints can be useful for us. Yeah, it prevents the immune system from attacking our own body cells. But in the context of tumor cells, it actually prevents our own body from attacking the tumor cells as well.
So the checkpoint is actually our body mechanism or the tumor's mechanism?
It is actually a receptor that's present on our white blood cells. Yeah.
In the white blood cells.
So that's why our white blood cells doesn't attack all our normal tissue, right? So it is basically a signaling thing to tell the white blood cells that I am attacking this thing that's bad. Yeah. So that's why certain disorders such as autoimmune conditions exist, because there's a failure of the own immune system to not attack their own normal cells.
Okay. So hang on, I'm a bit confused here. So the white blood cells function to attack something not normal, including cancer cells and including virus, bacteria. So
that's right.
With regard to checkpoints, what happened again?
Okay.
Checkpoints.
So the checkpoint is basically like when you have something that's bad, the immune cells will go there. All right.
The checkpoint is in the immune cells.
That's right.
Okay.
So what tells the body that this is bad? All right. Okay. What tells the immune system that this is bad? Okay. Because there is no checkpoint inhibition. All right. Basically, viruses, they are bad. They are unable to tell the immune system, stop, don't attack me. Okay. But cancer being cancer, if they have acquired an ability, right, to activate the checkpoint on the white blood cells, all right, then the immune system cannot attack them.
So the cancer inhibit the checkpoint or activate the checkpoint to survive?
It activates the checkpoint, all right? It basically signals to the white blood cells, all right, don't attack me. Yeah. So it activates, all right, the stop button.
Activate the stop button. Activate the stop button. So if activate the stop button, should stop.
That's right. So that's right. They activate.
Stop attacking.
That's right. They activate the stop button on the white blood cells.
All right.
Yes, the white blood cells,
now clear.
The immune system cannot attack them.
Yes. So in the context of cancer cells, immunotherapy, what happens?
That's right. So what we do is immunotherapy, all right, inhibits these checkpoints. So basically, the immune system, or rather the cancer cell, presses on the stop button, right? So immunotherapy removes, right, that contact. So imagine right now the tumor is actually pressing on the white blood cell and says stop. Yeah. And what the antibodies, the immunotherapy does is that it actually removes that activation. Yeah,
Remove the stop.
That's right. It removes the stop button.
So
it
attack
removes,
again.
That's right. So now, right, there's no stop button. Yeah.
Okay.
So in oncology terms, this is called lifting the brakes off the immune system. Yeah.
Interesting.
So there's a checkpoint there, right? The immunotherapy lifts the brakes off, and so the immune system can go ahead, yeah, and kill the tumor.
So this one is very non-specific then.
I would say that it is non-specific. Yes, you are right. But yet at the same time, the immune system shouldn't attack normal cells. Yeah, because after
Okay.
years and years of education in our body, most people, the white blood cells shouldn't attack normal cells. Yeah,
So the side effect of this immunotherapy removing the stop, it can cause the cells to attack our cell.
absolutely. Yeah,
Absolutely.
you
Okay.
are absolutely right. So therefore, although immunotherapy is very effective for certain types of cancers, one of the main side effects, all right, that's commonly seen that we watch out for is actually autoimmune side effects. Yeah.
Okay.
In general, autoimmune side effects can range from very mild to very severe. The good thing is that if we need or if we identify severe side effects early, we are able to reverse the immunotherapy. For example, by suppressing the immune system, by giving steroids, all
Yeah.
right, the very same immune system that is attacking normal cells instead of tumor, we will suppress it. So therefore, early recognition is key. But for most patients, the immune system is able to distinguish between tumor, all right, and normal cells. So
Okay.
this has led to the, I would say, formation of certain what we call predictive markers as well. So for certain cancers, we actually do an immune score. So remember just now we were trying to identify the targets, right? On cancer cells, right?
Yeah.
So we are able to also take a look at the tumor cells and see, are there many white blood cells surrounding the tumor, all right, where we examine it under a microscope. So if there are a lot of white blood cells and they're actually binding to the tumor but not able to kill the tumor, all right, these patients have a very high immune score. So they just need a bit of help for the white blood cells to attack the tumor. Yeah. So
Okay.
patients with high immune score, there's a higher chance that immunotherapy will work. There
Okay.
are other markers as well. For example, if someone has a defect in terms of the production of a repair protein, yeah, we know that the tumor cells tend to look more different than normal cells.
Right.
So when you lift off the brakes of the checkpoint, all right, as the immune system zooms through, they are more easily able to recognize the tumor cells because they look very different. And therefore, they are more likely to kill the tumor cells rather than normal cells. All
Yeah.
right. And so sometimes even before we zoom in, we will do all these tests.
Can you set how strong is the checkpoint? Like, is it like a spectrum or just switch on and off button?
Okay, there are actually many different checkpoints on the white blood
Oh.
cells. Yeah.
Yeah.
So the most common one that we actually use is this checkpoint called PD1. Okay, PD stands for program death. Yeah. So
Yeah.
PD1, but there's PD2, you can imagine. Okay. So there are other different checkpoints like CTL, yeah, as well also. Yeah. So it's not as if we have all the different checkpoints for all the different tumors. Yeah. But in general, the principle of them working is the same.
You so in oncology, you have a lot of toys to play with. Like in orthopedic, we
Yes.
use a lot of implants.
Yes, we have a lot of toys.
Yeah. Okay. I think we will run out of time. Can I just ask, chemo, targeted therapy, and immunotherapy, do you use all of them together, or how do you use it?
Okay. So generally, how we use really is determined by trials and studies. They usually do very preliminary studies to see if the combination is firstly safe. Yeah. And then if it's safe, sometimes they use combination.
Right.
And sometimes they will compare combination treatment with just the use of one type of treatment. And so really it's a matter of comparing all the different treatments, and then they try always to improve on the standard of treatment.
Right.
So for example, long ago, it was just chemotherapy, right? And then we found immunotherapy. So there may be a study that may look at just chemo alone, chemo and immuno, or immuno alone. And then we see which one is the best, right? And then that may emerge as the new standard of care. So different tumor types have different combinations or even just single way of treating.
Right. In terms of cost, how is it, Thomas?
I would say because immunotherapy as well as targeted treatments are relatively newer drugs, they are more expensive. And that's also because a lot of them, the copyright or the patents are actually still in effect. However, I would say that as the patent expires and as other eventual similar, what we call biosimilars emerge, hopefully in the next 10 to 15 years, the cost of all these treatments will come down.
Okay. Thomas, thank you so much for your time today. I'm also learning a lot.
You're welcome, Tony. One of these days, I need to learn about all the different implants and things that you use and toys that you use for your surgeries.
Right. Okay, and I really hope that this conversation is useful to many people, especially those who have cancers and want to find out about chemotherapy, immunotherapy, targeted therapy. I hope we have provided you with some more information so that you can understand your treatment better. And once again, thank you so much, Thomas, for your time, and thank you everybody for listening, and I hope to see you again in our next video. See you again. Bye-bye.
Bye.